Hello and welcome everyone to today's webinar on transforming spaces and places of patient engagement to promote health equity. We're very excited to be with you here today. For those who joined the first session back in October, first, welcome back. As a reminder, this is the second of a three-part series called Engaging with Everyone, and we're very excited to be moving along with this session. My name is Caroline Wong. I'm the executive co-director of an organization that's called the Center of Excellence on Partnership with Patients and the Public. And as with your last host, Heather Thiessen, I'm also part of the leadership team of the National Health Engagement Network. And I'm always so happy to be part of this amazing community and really excited for the discussion and the content that we're going to hear today. So I will be your host today. Please note that the session is also being recorded. For those who might want to view this later. Now, just to get started, we have a few housekeeping items. We are pleased to offer French simultaneous interpretation provided by Boost Events, a subsidiary of Boost Lingo, for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation button at the bottom of your screen. If you do not see the interpretation menu on your screen, please select the icon with the three dots inside a circle. It will be on the toolbar on the bottom of your screen, the More menu, and select Interpretation. So give a moment for some people to do that if you want to have the French interpretation. And for the slide visuals, we invite you to access the View Options menu at the top of the slides to select your language that you wish to use today. To see today's slides, as we do also have the slides in English and in French. If you are using a newer version of Zoom, you can also choose the slides you wish to view by selecting the appropriate tab from the top of your Zoom screen. So I hope everyone who wants interpretation has been able to do that. Si vous voulez parler, écouter en français, vous pouvez faire les sélections maintenant. So now I would like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. And in particular, I acknowledge that I'm broadcasting this webinar from Montreal, also known as Tchokchake, which is historically known as a gathering place for many First Nations, and the Kinakarake Nation is recognized as the custodians of the land and waters on which I join you from. We and I recognize and deeply appreciate the historic connection to this place and the opportunity to gather with you here today. Please feel free to introduce yourself in the chat function for those of you that want to, and reflect on the lands from where you are joining. And if you're unsure, you can also look to native-land.ca for guidance to better inform yourself of also where you're joining us from. We invite you to share your questions and comments at any point during the session using the chat box, which will be addressed during the question and answer period following the presentations of our speakers today. We'll also be dropping an email into the chat box for you to connect with us on any questions that you may have. And if at any point you need technical support at any time during this webinar, you can reach out to one of our producers using the chat feature. Just send a message and we'll do our best to help you. At this point, I would also like to give a huge thank you to the Healthcare Excellence Canada production team and the interpretation team who are behind the scenes to make this a smooth webinar experience for all of us. It's always a challenge to run a successful webinar for hundreds of people. And so it's really great to have this production team to make it all go smoothly so that we can just focus on listening and the content that will be delivered today. So now we want to take a few minutes to get an idea of who's with us, because obviously we're talking about engagement. And so we want to know with whom we're engaging. We invite you to answer two questions that will pop up on the screen shortly. Please ensure that you scroll down, because in order to get to the other question, you have to scroll down. So please ensure to scroll down to complete both questions prior to pressing the submit button. So we'll give maybe just a second there. And what I love about Zoom is we can always see as people are responding, so we get an idea live as to who's there. Maybe we'll just give a couple more seconds. So for those of you that are just joining us, please take a moment to respond to the poll that has just popped up on your screen to let us know where you're joining us from, who you are. And so we have an idea of who we're engaging with in this community and for this amazing presentation to come. I think you can also, as a reminder, you can also send us an information in the chats and let everybody know where you're coming from. So I think that's great. Maybe we'll close the poll shortly and then we can move on. Remember to also respond to the questions below. Perfect. So thank you all for taking the time to join us today. Again, as a reminder, this is the second webinar in our three-part series focused on equity promoting patient engagement, hosted by the National Health Engagement Network, or the NEN, in partnership with the Equity Mobilizing Partnerships in Community, or the EMPaCT, at Women's College Hospital and supported by Healthcare Excellence Canada. For those of you who aren't familiar, as I know some made this maybe one of the first times that you're joining us, the NEN, or the National Health Engagement Network, is a national community of practice made up of healthcare leaders, providers, patient and family partners, and essential care partners. Our goal is to advance patient and public engagement in the health system by sharing information, best practices, and resources, building capacity for implementing effective engagement and partnership strategies, and promoting collaboration among a diverse range of disciplines across the country to drive national patient engagement initiatives. We're just here to learn from one another and really honestly have a good time together too sometimes. So equity promoting patient engagement is core to the NEN's mission, and this series will to deepen our collective knowledge, help build capacity, and promote initiatives that center equity and patient engagement. If you're interested in learning more about the NEN, please visit the NEN webpage on the HEC website. And if you're interested in joining the network, please get in touch by email. And we're going to, the production team will share both in the chats in a moment. Now let's get to why we're all here. So this webinar series has been exploring several critical questions about equity promoting patient engagement. During the first session, we examined the key principles guiding this approach, setting a foundation for deeper discussions that we hope we can have today. Today is the second session, and we're diving into how power imbalances affect patient care, something that everybody. Be sure also to flag in your agendas to join us for the third and final session that will be held on December 5th, where we'll explore strategies to harness the power of lived experience to improve health outcomes for all.
It's certainly my pleasure to introduce the team of speakers for today's presentation. We're honored to have 6 members of Equity Mobilizing Partnerships in Community, EMPaCT, with us today, including 2 returning presenters and 4 who are joining the webinar series for the first time. EMPaCT is a novel and scalable patient partnership model co-designed to center the voices of the diverse community members and build capacity for equity promoting patient-oriented decision-making in healthcare. It was co-initiated in 2020 by patient-oriented researcher Dr. Ambreen Sayani and the patient partner Elise Mabey, who set out to challenge exclusionary patient engagement practices in healthcare, both of whom are here today. Since 2020, EMPaCT has been mobilizing the power of lived experience to ignite a health equity movement with a vision for a future where health and social care systems are inclusive, just, and shaped by the people whose lives are most impacted. Over to you, Ambreen.
Thanks so much, Belinda, and appreciate you quickly jumping in to pick up from Carolyn. So both you and Carolyn have done a great job leading us into this discussion today. Also want to take a second to acknowledge the huge team effort that goes into putting on something like this. Healthcare Excellence Canada, the National Health Engagement Network, Women's College Hospital, phenomenal team effort to get us here, but also our many funders, the Canadian Institutes of Health Research, the Public Health Agency of Canada, the Ontario Sport Support Unit. But most importantly, the members of EMPaCT, who from the very beginning have shared a belief that we can create a better and socially just system for all. Elise, I'll pass it over to you. Next slide, please.
So when we co-created EMPaCT, the group decided on some basic rules of engagement, which I'll share with you today. The first is to speak from our heart and not just from our head. The second is to commit to listening from our hearts with curiosity and respect, and not thinking about what we want to say while others are speaking. And the third is to trust ourselves, not putting forth ideas that we think we ought to have or that we're told to have, but the ones that are genuine to us. And finally, we want to share courteously, so we want to be mindful of time and share our time so that we can learn from each other. Next slide, please. So this is us. This is the EMPaCT community. And here are our members that you can see here. To learn more about us, you can go to our website where each of us have shared what we choose to share so you can get to know us better. We don't label people or use prescribed categories because we feel it's restrictive and sometimes harmful. The thing that unites us is the shared value of helping to create an exclusive healthcare system. Next slide, please. So since I'm talking, I'll lead off the introductions. My name is Elise Maybe. And as a patient partner since 2011, I'm well aware that I'm the usual suspect, female, white, and older. But I have been very interested in the challenge of how to involve diverse perspectives authentically for the purpose of advancing health equity. So I'll turn it over to Isra to introduce herself now, please.
Hello, everyone. My name is Isra Amsdr. I'm currently a graduate student at EMPaCT University in their Design for Health program, and I'm also an avid advocate for young women and girls who share my story.
Ryan, do you want to go next?
Hi, everyone. Pleasure to be in front of you today and chatting with you all. My name is Ryan Hinds, and I am currently the Director of Equity, Diversity, and Inclusion at the Dalhousie School of Public Health at the University of Toronto. I have spent some time leading some patient engagement work within Ontario Health, and so I'm hoping that I've actually crossed some paths with some folks today who are in the audience. Thank you.
Tara?
My name is Jeji. I'm a physician by training. My work has been in the last 31 years in health research after I got injured in 31 years, and I have a spinal cord injury. I have a physical disability. Over the years, what I have learned, having an insight into the needs of people in health, research, and community participation, being myself as having a lived experience, that what I have shared. And I've really rigorously been engaged in many boards, many community boards, in engaging patients as well as the healthcare providers to come on table and discuss freely, openly, and be part and parcel of the delivery of healthcare. So currently, I work as an independent consultant in research and health, and I've worked on both sides of the border in US and Canada for many, many years. So I bring those things in helping in designing EMPaCT from the very beginning when we had started it. So I have known many of the people here from the very beginning. So over to you, B. Thank you.
Hi, I'm B, person of color, homeless, anti-poverty advocate. Thank you. Pass it to Ambreen.
Thanks so much, B. I'm going to introduce myself by, it's a way we often introduce new members to EMPaCT, and the way it goes is, well, what can you tell by looking at me? What you can tell is that I'm a woman, I'm a person of color. What you can't tell by looking at me is that I'm an immigrant to Canada, that I come from a religious minority, that I'm sandwiched between caring for my parents and my children. And it's important for me to tell you this because all of us grapple with systems and structures at different points in our lives. And today's conversation is really grounded in how do we talk about those systems and structures so that we can have a better world for all. Next slide, please. So this is our working group charter that members of EMPaCT created right from the start. And last time we spoke to you about how we're invested in growing relationships of trust by genuinely listening and learning from each other. Today, the conversation is about how do we share power to do that. And the next time you tune into our conversation, it'll be about changing the conversation to build a health equity movement. Next slide, please. But today is about patient engagement, it's about power, and it's about sharing power. If we could run the poll, please. We'd like to do a bit of a pulse check to see how everyone feels with some of these concepts. Perfect. Thank you for taking time out to answer to this. And we'll just give you a couple of seconds. You will have to scroll down in order to be able to access all of the questions. Thank you. And I think with that, we can move over to the next slide. And Ryan, I'll pass it over to you to take over.
Thanks so much, Imbreen, and always happy to chat about how we can engage more effectively. So as I mentioned, I spent a few years leading some community engagement at the Toronto Central End, and then when I became Ontario Health Toronto region. And so what I'm hoping is just to share some of my learnings and hope that those can be helpful. I imagine folks are here today because we all are wanting to engage better, and in that there's a desire to create a space where people feel more comfortable engaging and bringing their valuable experiences forward. Now, I think we can all acknowledge that whatever engagement spaces we create, there are different levels of power and different levels of power imbalances. And because those power imbalances can so impact how comfortable folks are in the space to bring that experience forward, it's worthwhile exploring ways that we can share power so more of the people in the room can engage more meaningfully. Next slide, please. But to understand those imbalances, it's helpful to start here with our social location and our social identity. So that refers to how society and culture values parts of our identity. Those parts like gender, race, ability, wealth, religion, etc., there's lots here, all get assigned a certain value by our society that we live in. And inherent to those values are certain and different levels of power. Now, in addition to the value and power, it also often shapes how the world interacts with us. And how the world interacts with us shapes our experiences. And in shaping those experiences, it can highly influence the perspective that we're able to bring to conversations. More importantly, though, it shapes the perspectives that we aren't able to bring into certain conversations. And so those understandings are things that are critical for us as folks who are in the engagement space to make sure that we're staying cognizant of. If we jump to the next slide, please. So as those perspectives and limitations in perspectives continue to influence culture and policy, they become part of the systems that we all live in. And that's how we end up with system and structural inequities. So those show up in our institutional policies, they show up in our processes, and quite unfortunately, those often go unnoticed because the folks that are designing those aren't bringing the perspectives of the folks that are actually being impacted by those. And so those social inequities do so much to continue to further create inequitable spaces for people to engage. It's important for us to be able to recognize those and then address those. If we jump to the next slide. So what does that mean for us when we think about patient engagement? So as I mentioned, I spent some time doing engagement sort of at that institutional level. And I think we're looking at a picture that all of us in the room who have been part of these sort of institutional level engagements can probably recognize. It looks a little bit familiar, right? It looks like a sort of a typical patient and family advisory table or a counselor, whatever we chose to call it. And for quite a while, I definitely led some of those conversations, and these exist within hospitals, health authorities, health agencies. This model is one that we know is prevalent, and not to say that any model in itself is good or bad, but what we should know and what we should be able to do is identify where the imbalances and where the power structures are within the models that we have. I often sort of liken it to having a cold, right? So if I have a cold, and I know I have a cold, I can do things to now make sure that I'm not spreading that cold around and impacting the people around me. So I can don a mask, I can make sure I'm creating space. But if I'm entering a space and I don't know that I'm sick, the impacts that I'm having on people, I don't even know that I'm having them on those. And so for folks who are in the engagement space, if you aren't able to identify your social location, if you aren't able to identify what the power imbalances look like within your own patient engagement structures, you're having an impact and you may not even know it. You may not even be aware. So maybe we can jump to the next slide and talk a bit more about what that patient and what that power looks like within patient engagement spaces. And so if we think about what that particular model looks like and what these models typically tend to look like, it, it typically tends to look like folks coming into rooms during the middle of the day and having conversation with us about a topic that the institution decides on what we're going to engage in. Now that in itself limits people in not only who can be in that room, but it limits who can engage in that conversation. It also says that the topics that we're going to talk about are the ones that we're going to decide, or in organizations that want to do this better, they sometimes bring an option of topics to talk about. But how often is it that members of the actual advisory table are dictating which topics that they want to see come to the table? How are we setting up the rooms so that folks all feel like they're able to engage? What is the natural power structure and inequitable structure that exists when there is a person who is guiding conversation, as opposed to there being shared power within that structure? And so again, not that any particular structure is a bad structure, but it is inherent to recognize or it is important to recognize what those inherent structures look like when we design what our engagements are going to be. If we jump to the next slide, please. And so I'm going to pass it over as we talk about that sharing power. I'll pass it over to Ambreen, who can talk about what that shared power can actually look like.
Thanks so much, Ryan. And I love your point that, if we don't really contest with these issues, then the impacts that they have go unrecognized. And power, next slide, please, is such an invisible force unless we allow ourselves to contest with it. And because it is pervasive through language, through norms, through cultures, we really need to take a step back to be able to bring it to full light. And that's what this conversation today is really about. Some of the topics that we'll touch upon are like power over. So like between two groups of people, how does one influence the other group? What degree of power do I have to influence things individually? And then when we act as a collective, how can we mobilize around a shared goal? And this power with idea is really one that's entrenched into the development of EMPaCT. Tara, I'll pass it over to you to talk a little bit about EMPaCT. And next slide, please. Thank you.
Thank you. So here is our acronym EMPaCT. So I think each word has its own power, its equity. We are mobilizing partnerships, and it is community-based. So, and if you look at this jigsaw puzzle, there's so many things come into when we are designing an engagement model and what we call our impact model to be an co-design model. So we have touched on how different things we look at when we are bringing people together, but how do we put those together to make it one unit is most important. And we are bringing diverse community with different educations. In this group, we are very different with different backgrounds. We have all shared in our introductions, and we are trying to bring their voices on the table to drive equity promoting decision making. And two important aspects for everyone is healthcare and the social fabric of the society. And in the end, what is our end goal is inclusive and impactful partnerships. And just to give an example how far back some of the members are, that I met Ryan in June of 2018. He came to my office. I used to work in Midtown Toronto, and he talked to me about what work Toronto Central was doing, as he shared that he was there as the community engagement person. So he did a marvelous job. He brought those learnings shared, and he has brought those learning from EMPaCT. So we can do better than what it was done on that table. And he shared the picture, what institutional partnerships are in engaging patients. But we are unique or different than others are that we have co-designed the model, we have equal power sharing, which you will be hearing a little bit more about as we go along. Next slide, please.
Flipping the table aims to highlight how the power rests within the table itself. EMPaCT aims to switch the power dynamic so that when people consult with the EMPaCT community table, the power lies with us, the community members, and allows for equal engagement between patient partners and decision makers. The conventional model of patient partner engagement presents an unequal power dynamic and puts patient partners in positions of inferiority. Therefore, when we flip the table, we foster an environment that is driven by the community. Next slide, please. So this is the process of consultation that EMPaCT utilizes. The goal is to allow us to shift the power dynamic within each step and essentially work towards flipping the table. The actual consultation with the EMPaCT is only one of 4 steps. There is a necessary process before and after the consultation to ensure that the engagement occurs on the terms set by the members of the EMPaCT community and does not inflict harm. Next slide, please, and I'll pass it over to you, B.
Patient partner can be involved in creating change in policy and society in different levels. This slide shows that what we have been doing in EMPaCT in terms of sharing power to create change.
Next slide, please. Thank you, B. Elise, is there something you'd like to add here?
Yeah, so I just will wrap up what my colleagues have said. Tara talked about how we came together as a group to use the power of the collective, and Isra talked about the flipping of the table changes the power dynamic and how we co-created processes for sharing power. And B has shown us how EMPaCT can make an impact on since we started. And so I don't know, Ambreen, if you have anything more to add to that.
Yeah, sure. I'm going to, talk about Audre Lorde a little bit. And Audre Lorde writes about how the master's tools can never dismantle the master's house. And the idea is that power can be determined by the oppressor. And unless we totally go about and create new tools, we won't be able to undo the oppression. So EMPaCT is an example of that. We went about and co-created a completely new model of patient engagement because we wanted to challenge the status quo and create a new toolbox. But part of that has also been co-creating a tool that makes visible power dynamics, and that is the Power Wheel tool that we'll introduce to you today. The whole idea, if we can move on to the next slide, please, actually. Next slide, is if we can begin to make visible all of the different ways in which power plays out, then at least we have something to have a conversation with, or else it is invisible, unseen, nothing to be spoken of, and in the very worst case scenario will perpetuate harms and inequities. So the Power Wheel is a tool that really, the idea was inspired by the Power Cube, which was created by Gaventa in the field of international development. And we thought, well, how can we take that idea and concept and pivot it to the idea of patient engagement and the world that we're embedded in right now? And what we walked away with is the idea that place is a really important way to determine the level at which people have influence. Space is really about relationships between people in those conversations, and influence is the idea of how much can I actually have a say in what needs to happen to advance my own health and well-being. We encourage all of you to use the QR code, interact with the Power Wheel tool, and share a Power Wheel that relates to a project you've been involved in. Let's make visible the invisible power dynamics that have been happening in our spaces so that we can have a conversation about what this looks like. Next slide, please. And I will pass it over to you, Isra.
So within power and place, there are 3 levels in which this can take place: micro, meso, and macro. Micro, as the name implies, is the smallest level and can entail a project that I'm working on at my local hospital. Meso refers to intermediate level projects that create impact within a particular organization or community. For example, this entails the work that I do with the health team in my neighborhood. Finally, when we look at things from a macro level, we're looking at wide-scale impact at either a social, economic, or political level. This can entail the work I've engaged in with the National Health Agency. Next slide, please.
Where committee members are invited to share their living experience. This slide shows the importance of power and space. When space is closed, we are not invited to have opportunity and space to engage in decision making. For people to have decision made about them without them, especially about something so fundamental such as housing, it creates unintended consequences. For example, the encampment people. When decision making occurs without involving or engaging them by just moving or evicting them out from park to be housed. Result are some people put a tent in their house. Some people go back to camp again in other park because they are not used to live in a house as sky is their roof. They feel suffocated when bound by four walls. If they are invited, they have opportunity to share their perspective. City may understand and not evicted them from encampment, but if they are given the power such as in EMPaCT to create their own space, they can influence the city by requesting city to come up with a transition pathway plan that will help them move from encampment to housing and maintain their housing and end homelessness. Next slide, please. Over to you, Tara.
Thank you, Bea. So here we are talking about how power has an influence and how we share the information. When we go from very lower level or very beginning, what was the processes? So we are moving from inform to decide. Inform is just letting patient partner provide information at what is being done and what is means for them. Patient partners have really no influence. So you had seen the photograph of a hospital setting or a healthcare setting, and people sit around it, and we bring patient partner, let them know what's happening in the hospital setting or in the system. If we are making any changes to the system in a hospital, is there care being provided? How is it being done? Any antibiotics changes are being done, or any care of the patient in the hospitals are done. Those are the way they are informed of how it is being done. Secondly, they are brought to the table to consult, to let them know this is what it is and what is some of their feedback which will be taken into consideration. But we are not sure if that will be taken into the final decision-making processes or not. Then third, one of the levels we can say, or ways we can say how it influences is patient partner work together and decision makers to develop some alternatives for what is not working. So there is a model they have developed of giving vaccines in the community and doesn't work because they don't have enough people who are ready to get vaccinated, especially for a new vaccine coming into the systems. And then they try to collaborate and find out some of the solutions which patient partners can give them and which can be taken into consideration. But really, other one is the decision-making process, which impact usually follows. So we make decisions together, and so that each one of us are co-designer in those decisions which are finally made. But that they are unique by some of the decision with other patient partners make, because some of those decisions are not equally taken into consideration. There is still some impact of power on that. So these are the system ways, and hopefully as we move along with time, people will try to see that best way to implement will to take people in co-designing and in making those decisions which will impact them. Next slide, please.
So before I turn it over to Ambreen, perhaps I can just sum it up. We've just learned from Tara and Isra and B about the three, getting into the definitions of the three dimensions of the power wheel: place, where the work is situated; space, that is afforded to us as patient partners, if you will; and the influence, the degree of influence that Tara talked about that we have, which is dependent on the way we are engaged. So Ambreen, over to you.
Thanks, Lee. So we really encourage you to check out our publication and visit the tool and interact with it. These are some of the ways which we envisioned it could be used. The first is really to report. Go to the tool, create your own Power Wheel, download it. We're currently running a hashtag called #PowerWheel. You can tag Women's College Hospital, upload your Power Wheel. That will allow us to see what power looks like. Because right now we have ideas or assumptions of how power operates, but we don't really have a clear vision of what it looks like on the ground. So the more of us that participate to this conversation, we actually create a landscape view of how power currently exists within our systems of patient engagement. Once we can see it, we can have a conversation, because I think, in all fairness, no one of us has the authority or control to change this. But as a collective, we can have a really substantive conversation. And then we can create, some next steps, solid action items, and work to resolve some of those. Next slide, please. And I'll pass it back to you.
Yeah, so I'm going to just run you through three examples of the use of the power wheel, and I'll start with the example of EMPaCT as a community table. So we are we handle things at a macro level because we deal nationally. We can also deal locally, and we can deal regionally. We are also a space that's been created. We co-created it amongst ourselves as patient caregiver partners, largely. And so we have, as we've learned, made the decisions of how we operate, who we operate with, how we go forward, and the decisions we take. So we are also a decide. We're at the level of influence of decide because we make our own decisions. Next slide, please. So now I will take an example from one of the engagements that we had, where a federal agency came to us to ask for some advice and recommendations around equity for the work that they were doing. So they were in the macro space, they were national. So they came to a created space, which is our space, as EMPaCT, and we collaborated with them and gave them some recommendations on how to go forward. So that's how that example would use the power wheel. And our final example, next slide, please, is a basic quality improvement example. And I'm thinking of the several quality improvement projects that I have been on, where it's usually been micro. So at my local hospital, there was a unit or a process that we looked at. So that's the micro level. I was invited as a patient partner to be part of the team that looked at the quality improvement that we were tackling. So it was an invited space. And then finally, I was engaged at the level of consultation. In most of them, occasionally it would be the level of collaboration, but in the instance I'm thinking of, it was a consultation. So that's how we can use the power wheel to describe what that type of example is. And I will say next slide, please, and I will turn it over to, I guess, my colleagues to comment on what they, one thing that they want everybody to take away from this webinar. So I don't know who wants to start. Perhaps Tara, you can start. You're on mute, Tara.
So I would start from here and think, as we are all collected here, work together for an inclusive world where everyone can participate.
Thank you. B?
give people with living experience the shared power and space to influence policy and systemic change. Thank you. Over to Israel.
I'll end it off saying, remember, you have the power to change who has power.
Great. Okay. Thank you. And maybe I'll jump in and ask us to jump to the next slide. And so I just wanted to reflect a bit on maybe some of the things that we've heard, and knowing that this is a tool that we can use to at least reflect on maybe what our structures looks like and what our engagements look like. It's a tool that can help you sort of reimagine what your engagement structures look like. And I think understandably, as folks who sort of lead and move within the patient engagement space, we understandably lead towards things that fit within our system or our structures that we have. And I think those things tend to work. We don't want to sort of disrupt too much. We want to make sure that we put something in place and then implement it so that it can actually function. And there's some good that can come from that. But I think the question should be asked that if it fits nicely into what is already existing, and we already know that some of the structures that we have are structures that are based on power imbalances and inequities, what space are we actually creating? What can we really create? Can we really create an equitable space that fits nicely into an inequitable structure? That's a question that we should be able to ask ourselves. And then think about, well, can we be this disruptive? If we start from the position of this won't fit nicely into my existing structure, what from that position can we start to reimagine? And if we're not able to sort of start from a position to say, okay, well, this won't fit nicely into my existing structure, then you should be able to ask yourself the question and answer, what systems are we acknowledging that we're going to move forward with, right? And so I think those are questions that we should be able to ask ourselves when we think about the structures that we're creating for patient engagement, and thinking about what the objective really is for that engagement. And Breen?
Thanks so much, Ryan. If we could go to the next slide, please. I think I just want to say in closing that we have developed a new model, we have developed new tools, but certainly these aren't the solution or the only solution. These are things we have thought about. These are strategies we have thought to be effective in our space. And we want to share them because as a collective, we can have a conversation about these issues and not work in isolation. So it really is about partnerships. And again, just moving through our working group charter, we've spoken to you today about sharing power, but in the sharing of power, we have the ability to change the conversations that are happening. And in particular, if we're thinking about health equity as a goal, it becomes even more important to not be exclusionary and to think about those systems of exclusion that are set up in the way we currently operate. To build a health equity movement, we need to first and foremost acknowledge those systems, recognize how power is shaping those systems, and then be able to have a conversation about it so that we can implement effective change. Next slide, please. So with that, we're going to run an end of session poll. If you can please just let us know how you feel towards the end of this session, and then we'll bring it to a close by talking about what you can tune into next time. Once again, please scroll down to the bottom so that you are answering all of the questions. And we, again, really appreciate your participation in this because it allows us to reflect on how you feel about our tools. And it is a collective partnership between all people. Alrighty. So if we could switch to the next slide. So in December, we'll be inviting 3 people from the healthcare system who have engaged with EMPaCT. They bring a variety of different experiences and leadership roles, and we'll have a conversation with them about why did they engage with EMPaCT? What was the impact of partnering with EMPaCT in their projects? And why was that experience so different when it came to health equity and mobilizing knowledge? And I'll pass it back to Belinda or Caroline. I'm not sure if Caroline's here yet, or else it's back to you, Belinda.
Hi, everyone. Thank you so much. I am back. I hope you can hear me, but of course, I have Belinda on backup in case we have the same technical issues as we had before, and I do apologize for that. So it seems like everybody is responding to the poll, and it's really wonderful to see how our perspectives are changing. First and foremost, thank you so much to the EMPaCT team for this extremely informative presentation. There are so many gems that I took away from this presentation on making conscious these power dynamics, rendering the invisible visible, giving us the tools to really be able to start these discussions and open these spaces at these different levels, and really looking at this. I really love what was just said about looking at how we can look at creating equitable spaces inside of inequitable spaces, or really if that's a possibility. So I really think we learned a lot here. We're going to move soon to the question and answer period. I think we have about 12 minutes left in the webinar. And I also invite you to connect with the EMPaCT team, and the production team will drop the EMPaCT email contact in the chat. And of course, you can always check out their website, which I've already started to do with the links that were provided in the chat. I also saw that people are asking for more resources, etc. So we have noted that down, and the production team will make sure that we can get that information out. So I think we can move to some of the questions now. I saw a few. Are we going to stop the poll? Maybe close the poll there? And I did see a couple of questions that have come up. I was trying to gather them in a separate document, but maybe I'll just scroll back up. I did see one, so if you would permit me to just repeat what I was reading here. So from Sean Patnode, there was a question: did you find this model? So I think they were specifically talking about the different models of engagement. So did you find this model more useful than the Carmen model of engagement? And if so, why? And I think related to that, I think it was sort of maybe a question as to how your team inspired yourself based on existing models, but also adapted them. And there was another question that the model is also different to the model of the IAP2 model. Where it shows decision making here is done only by patient partners, and how do you kind of address the question of co-production? So maybe the first question about, I don't know who wants to start to answer those questions. Ambreen, I see you've unmuted, so
yeah,
go ahead.
I can go first, but I know between our group there's a lot of gems in everybody's brain, so I won't take too much airtime. Perhaps I'll speak, and then at least I'll pass it over to you. It took us almost 2 years to co-create the Power Wheel, and we did a deep dive into the literature. At that point, we'd been a model for 2 years and had done a lot of engagements at different levels of the healthcare system. So it was really about bringing those ideas and also reflecting as a group why people had been involved in different places and why hadn't they been involved. And when they were involved in spaces, what did it feel like? Could they even contribute? And what was the impact of that on their everyday lives? So it came from that. We do have data from almost 4 years of engagements that we've done now, and therefore, when we have the inform, consult, collaborate, and decide, it comes from our own data of tracking who engages with us at which level. The model is around two things: partnership between people with lived experience and the health system. So it's not just people with lived experience. It's a model that operates. The Power Wheel is about that partnership and recognizing the power within that to create differences in the healthcare system. So it's about power sharing within those partnerships. It cannot operate if it's just people with lived experience. And it can't operate if we're just thinking of decision making without the place and space being an integral part of how that decision making eventually rolls out. Elise, anything you'd like to add about some of the things we were grappling with?
So yeah, something that as a patient partner, I am very conscious of the fact that I actually have no agency to make change, because the levers of change rest with the people who are the professionals in the system. So the best agency I have is persuasion and the sharing of experiences. So, as Ambreen said, we can make decisions about certain elements of what we do and who we do it with and so on. But in the end, whatever is decided is really decided together. We may make some strong recommendations, but the actions based on those are always rest with the people in healthcare who have the levers of change. So that's one observation I will make. But I will also say that the experience of being involved with EMPaCT, where we share decision making, has been mind blowing for me because as a group, we have made incredible decisions in my books because we stop and listen to each other and learn from each other and then go ahead collectively. And the power of the collective is really amazing. I think that's something that I've really learned from this experience. And I don't know whether anyone else wants to jump in on this subject. Ryan, you're unmuted.
Yeah, I think anytime there is a shift in an approach that you're familiar with or less familiar with, there can be a bit of discomfort in sort of understanding maybe what that looks like. And I feel like that discomfort is actually a good place to be in, and a good place and a signal that you might be doing something different outside of what the system might have shaped us to sort of think in a certain pattern. So I would say that my experience has been very much so that it has been a very shared model. And I think there's just given the different sort of seats I've sat in terms of organizing spaces and now being a sort of patient partner in certain spaces, there's definitely a shift in maybe what those conversations look like and the influence for how those conversations shape the next meeting or the meeting after that, and maybe what places those conversations can have. So I do think it's a shared decision making, but I think even in the category of shared, there's levels of shared decision making, and I think what's helpful here is to just explore what your level of shared decision making is, and if you can push that a bit further.
I love that. And I know just before Ambreen, I think what's important that you're mentioning there is also to remember that it isn't just a one-off, it's a continuum, it's an evolution, it's a process, and it's really learning together. So I think that's fantastic. Ambreen, maybe one comment, and then we actually have one other question that we can hopefully get to before the end of the session.
Sure. I just thought it was important to comment on this. Isra spoke to a slide which was, 4 levels during which we share power. So it isn't a one-off where we're throwing people together and hoping for a good outcome. We actually meet with people from the healthcare system who are the actual decision makers because they have that influence. We're able to contribute to that influence. But we meet with them 2 or 3 times before the engagement. And that's how we refine how they will engage with the community, which parts of their project are amenable to change. And that's how the shifting of power happens before we put people together for a conversation. So it's really a very structured process that makes the model what it is. And with each step, there's systematic shifting of power in the EMPaCT model. But happy to share more in our next session in December, which is exactly about how we do that.
Perfect. There's actually more than just one question, so maybe I'll try to get to a couple of them. So the next question is for organizations that are very top-down, command and control style, how do you break down the barriers to ensure a collaborative environment? And I think if also I'll maybe throw out a second one as well, just in case we can respond to it within the next few minutes. So obviously everybody thanks you for the webinar, but there's also assuming that the Power Wheel is applicable to communities as well as individual patient partners. So maybe if you could cover these two, but it sounds like, yes, this is definitely something that can be applied to communities and not just individuals, or it can be used as a reference in those contexts. But maybe to address the question of breaking down those barriers in organizations that may seem, say, top heavy. Anybody want to address that? I mean, I think that's the point. Go ahead, Ryan.
So I think so there's rarely a this is going to work every time approach there, but I think it sort of goes back to maybe what organizations state that they value, right? I think you have to think about if we're looking at patient engagement and we're talking about how that intersects with what the organization values, we have to question if those values are actually being replicated by the processes that we have in place. And so I think when there is a very top-down structure that limits your ability to more directly pursue or more efficiently pursue the value that you talk about, you have to question whether we value those things or whether we need to change what our value states. Because if we're not living out what those values look like and how we operationalize or process things, then we need to think about what are we actually thinking is our value. And if we want to do that, then maybe it's the time to reflect on whether our processes actually allow us to get there. So in that piece, I think that's maybe the approach that I would take in terms of questioning what do we actually value and does our process actually reflect that?
Thank you so much, Ryan. You're getting some key responses in the chat there that it's really important that you brought up the question of values and how are we as a society kind of recognizing our own values and bringing it into practice. And that brings me just to the last point. There's a couple of questions and I'll try to summarize them. So obviously people are looking for examples of in practice among your resources, any publications based on the database of engagement work that you've done, any formal evaluations. I think you have already mentioned that you are evaluating some of that work. So I think there's some of that coming. And also, has this model been applied to more narrow projects, for example, in systematic review or evidence synthesis, or actually in clinical practice? So I think that's just all a clear indication that there is a great interest for this, but people are really looking for a practical way of seeing how this has been applied and how each and all of us can bring this into our daily lives and into the work that we're all doing. And I think that's the interest of the members of the NEN and everybody else that is joining us today. For those, I won't ask you to answer. Maybe, I don't know if Ambreen or Ali's right, quickly you can talk about the resources, but if not, I think with the production team, we can make sure that we share additional information, or if anybody else wants to add anything there.
I'll just say that our website has links to all of our resources. We have resources available in French as well, which will be uploaded shortly. The Power Wheel tool is interactive. Go in there, create your own Power Wheel, tag us when you do it. And the evaluation work is forthcoming, so stay tuned.
Wonderful. So we are 1 minute from the end of the webinar, but I actually think we have one more poll that we want to ask you to fill out, because so much of this is about building connection. We want to know how this has helped you build connection and how you might want to continue to interact with both this work and with the National Health Engagement Network and with EMPaCT. So if you could quickly, please complete the poll. It's just one question this time, and that'll give us an idea of how we can move forward. And once again, as you're filling out that, I would like to thank the entire EMPaCT team for their excellent presentation today, and to the amazing production team at Healthcare Excellence Canada, to my backup co-host Belinda for jumping in when we have technical issues and so that we can keep running smoothly. And of course, thank you to all of you, our audience, for joining us today. That concludes our webinar for today. Thank you so much for your engagement. Thanks for being here. And don't forget to put into your schedules the final webinar in this webinar series that will take place on December 5th. As you know, the discussion will continue to address these critical questions that we all need to be asking ourselves and opening the space to discuss openly and transparently. And we really look forward to seeing you then. Thank you so much. And we wish everybody a wonderful day wherever you happen to be.